Dr. Kolentinis with his lecture on CMR and valvular heart disease. He is a CMR specialist at Athens Medical Center and Iatropolis. Dr. Kolentinis, please.
Good morning. I would like to thank the organizing committee and Dr. Mavrogianni especially for this honorary invitation. It's really a pleasure to participate in this course. The topic of my presentation is the role of CMR in the assessment of valvular diseases. I know this is a big topic to handle, and I will try to be as comprehensive as possible. But let's start with the basics. How to assess a valvular disease? Well, we all know that transthoracic echocardiogram is a mainstay method for valvular disease assessment. There are several good reasons for that. It's the first method that was used for valvular assessment. It's easily accessible nowadays with widely available expertise. Most of the time, especially for stenosis, it's very diagnostic. You can, with Doppler imaging, you can very well measure velocity, maximum velocity, and you can somewhat quantify regurgitation using various methods such as PISA, vena contracta, and so on. The mechanism of regurgitation especially is most of the times clear, and also you can assess left and right ventricular function, especially with the new methods such as 3D echocardiography. But as every method, echocardiography has its limitations. First of all, especially for mitral regurgitation, the mechanism is not always clear, something that is very important when planning surgery. That's why we have to resort to transesophageal echo, which, of course, as we all know, it's an invasive technique. Regurgitation volumes and ejection fraction are approximation, and especially this applies for regurgitation volumes that rely on geometric assumptions. And of course, when we try to measure maximum velocity, which is the main technique that we use to decide about a possible surgery, we have to have good imaging and parallel alignment with the flow, which of course is not always possible. But of course, the biggest limitation of echo is acoustic window. You can see this patient, he has a thickened aortic valve cusps, and of course there are some artifacts in there, as you can see. So it's not always optional. When you compare another patient with aortic regurgitation, this is the three-chamber view. You can clearly see that this patient has two regurgitant jets. One is in the aortic valve, the second is in the mitral valve. You can very clearly see the contrast between the blood pool and the ventricular wall. So why do we perform CMR, and what features can we assess? First of all, ventricular anatomy. We use typically balanced SSFP sequences, which is the workhorse of our everyday practice. We use long and short axis stack in cine through the valve in order to see the morphology, with special revolutions upwards to 1.5 millimeters and tapered resolution typically in the realm of 25 to 35 frames per cycle. You can very well visualize this patient who has a bicuspid aortic valve. In the first image, which is the long axis stack, we can see that the cusps are opening in a dome way, and through the short axis, excellent visualization of the valve, a true bicuspid aortic valve. This patient has gone and has undergone a transthoracic echocardiography, which reports, obviously, this is severe mitral regurgitation due to mitral valve prolapse, but also what the echo missed was mitral annular disjunction, which may be clinically significant in some patients. We can measure flow, we can calculate the flow velocity. This is calculated with through plane phase contrast velocity mapping. It essentially, it is a map which encodes all the velocity in every voxel in the image. So the algorithm calculates the flows, the velocity through its voxel. Keep in mind that depending on which direction the flow goes, it appears either bright or black. But we have to manually approximate the maximum encoding velocity, the VENC, as we call it, in the sequence, in order to have as few artifacts as possible. So it's actually a compromise between high sensitivity and avoiding aliasing artifacts. And through that, we can do we can measure the flows. We can do flow measurements. We produce the velocity chart, and then through delineation of the vessel borders, which is the cross-sectional area, we can calculate with the continuity equation. This is familiar to all of us. We use it all the time in echo. It's the product of cross-sectional area times the velocity time integral. These are the two images, the MAG image, the phase image. You can see in the surrounding aorta, this is a true axial stack. You can see that the algorithm and the program automatically tracks the borders of the vessel, and through the chart and through the flow measurements, it produces this chart. This is a very helpful chart because it allows us to calculate the forward flow volume, which is this part, the backward flow volume, which is the part during diastole, and of course, the regurgitant fraction. This is a patient with aortic regurgitation. The visualization of the flow chart is very important because we kind of have some sense of that it could be severe aortic regurgitation because it has hollow diastolic blood flow reversal. This also through the volumetry, which is standard in every exam, we use the short axis Simpson's method. It's the same method that we use in echo, and which measures the stroke volumes from both ventricles, right and left ventricles. The difference in the stroke volumes is the regurgitation volume that we calculate. And of course, we can also see concomitant pathology. For example, this is a patient, he has bicuspid aortic valve. Excuse me. He has bicuspid aortic valve. The doctor saw it. They performed a 3D angiography, which showed a dilatation of the aortic aorta and also aortic coarctation in another patient. And of course, let's not forget fibrosis imaging, standard in every exam, I would say. We have to keep in mind that replacing fibrosis, either any kind of that, even if it's subendocardial, mid-wall, whatever, patchy, it's an independent and powerful predictor of adverse cardiovascular events in the future. Ventricular dysfunction. This patient has mitral regurgitation. The echo showed normal left ventricular fraction, but when we performed MR, it showed that ejection fraction was somewhat depressed. Let's talk more specifically about the two most popular valve disease, valve stenosis and regurgitation. So when we have valve stenosis, what does CMR show? It can show anatomy and anatomical orifice, which I would argue is maybe one of the most important, if not the most important, parameter that we measure. Maximum velocity, I would argue that the maximum velocity that we get from MR, we should be a little careful because we maybe many times we underestimate it. It will show us ventricular size and function, which is of course the golden standard and very important to decide if we have ventricular dysfunction. Fibrosis imaging, as I showed earlier, not only with late gadolinium enhancement sequence, but also T1 mapping, native post-contrast, and also extracellular volume, and of course, other pathologies such as ventricular hypertrophy, pericardial effusion, and so on. The most common valve stenosis is aortic stenosis, as we all know. We use the typical cutoffs that derive from echocardiography, which is maximum velocity of over 4 meters per second. For this reason, we have to set manually the velocity encoding parameter in our sequence to be a little higher. Maybe we'd start at 4.5 and incrementally increase it until we have our good imaging. We can also calculate LVOT cross-sectional measurement and use the continuity equation, the typical continuity equation. When measuring the anatomical orifice, we do planimetry. During systole, we do planimetry, and typically the cutoff value is 1.2 centimeters. In which case we consider it to be severe. This is a patient with severe aortic stenosis. You can see many things here. First of all, severe hypertrophy of the left ventricle. These black spots there are not black spots. They are actually severe calcification of the valve, and you can see in this short axis tag that the cusps are barely opening. Severe calcification with functional bicuspid valve. And of course, this patient had a maximum velocity of 4.2 meters per second. We had already set the velocity encoding at 4.5 meters per second. And of course, the mechanism of stenosis, for example, this is a patient, the valve does not look severely calcified, but he has a bicuspid aortic valve with a raphe between the left and the right coronary cusp. And of course, fibrosis imaging with late gadolinium enhancement, native, post-contrast T1, and of course, extracellular volume map. Other parameters, left ventricular function, LVOT diameter, and of course, as I mentioned earlier, planimetry. I think CMR is maybe the best method along with CT that can calculate really well the true anatomical orifice. Always remember to perform CMR, especially in patients we have a high suspicion before intervention, because they may present with cardiac amyloidosis, and which may be visible. You can see here in the interventricular septum. What about valve regurgitations? When assessing valve regurgitation, it's very important to have a visualization of the function. So that's why we use cine sequences in order to clearly see the regurgitation jet and mechanism. Sometimes we use gradient, typical gradient echo sequences, because they show better the regurgitant jet. We calculate through volumetry LV and RV systolic fraction and volume, and through this the regurgitant fraction and volume, which are actually the two parameters that we use in order to calculate the severity and decide for further action. This is a regurgitant jet. You can in the aortic valve, you can clearly see it. It looks black, and it contrasts really well with the blood pool. As for the mechanisms of regurgitation, the two patients, the left patient has mitral regurgitation due to posterior leaflet prolapse. The next patient has hypertrophic cardiomyopathy with systolic anterior motion of the mitral leaflets, so he has secondary mitral regurgitation. In order to calculate the regurgitation volume, we calculate the stroke volumes through volumetry. The difference of this, we compare them, and the difference is the regurgitation volume. Keep in mind that when it's calculated, it presupposes that no other valve has severe insufficiency, and of course, there are no intracardiac shunts. We can compare the stroke volumes derived from the flows with those derived from volumetry. For example, when we have a patient with mitral low tricuspid regurgitation, we can calculate the flow, and then the volumetry, and the difference in the two volumes is the regurgitation volume. But when aortic or pulmonary valves are involved, we can directly measure it through the flow chart, as I showed earlier. This is what it typically looks like when we have, for example, aortic regurgitation. This part here is the forward flow. This part is the backward flow. You can see clearly hollow diastolic flow reversal, and these are the measurements which are automatically calculated through our program. This picture shows the cutoff values for severity grading. For aortic and pulmonary regurgitation, fraction over 30% should be considered maybe severe, and for mitral and tricuspid regurgitation, it is somewhere 40%. This shows that for primary and secondary mitral regurgitation, regurgitation volume of over 40% should be considered severe. And why is that? These are some relevant studies which try to answer the question when the patients develop adverse outcomes. And for mitral regurgitation, most of which agree that over 40% regurgitation fraction, and for aortic regurgitation, somewhere in the mid-30s should be considered severe. As far as I'm concerned, I think this chart is maybe the most relevant. This is why I personally use regurgitant volume of over 33% for aorta or for the aortic valve, and over 40% for the mitral valve should be considered severe. Also, left ventricular end systolic volume indexed, as measured by CMR, is integrated, especially for aortic regurgitation. We showed it in the recent guidelines. Systole also is a parameter that we should use, and it's 45 mL per square meter. The comprehensive protocol that we use for mitral regurgitation lasts about 40 minutes, and it also encompasses most of the most important parameters, such as late gadolinium enhancement, 2D contrast to the aortic and the pulmonary valve, and also cine images. But we can also perform it in under 20 minutes using only cine imaging. As I mentioned earlier, it's maybe the most important, and also short axis stack in order to derive the stroke volumes through volumetry and the stroke volumes through the flows. No LG, no nothing. This is an interesting case. This is a male with septal hypertrophy in echo, which and the echo says that he has only mild aortic and mitral regurgitation. But when the left ventricle the left ventricle volumes are calculated, it seems that it is dilated. And we can see that he has an eccentric regurgitation jet in the aortic valve. You can see it here. It destroys the magnetization. And it seems that this patient has severe aortic regurgitation with a regurgitation fraction of over 33%. There are a few caveats that we have to be careful of. First of all is the velocity aliasing. It's the same principle that it applies in echo. We have to be very close to the true velocity in order to have this good flow charts. Otherwise, it should look like this one, which is obviously wrong. Also, we have through plane motion. This is especially important when we're trying to calculate aortic regurgitation because it can miscalculate the severity. Small mobile lesions on the leaflets are virtually impossible to truly assess. This patient has echo, actually refers this patient for MR, but he has some lesions over the mitral valves, but it's very difficult to assess. Although we have found some concomitant pathology in the non-coronary valsalva. And of course, valve prosthesis, very difficult to assess because there are severe susceptibility artifacts. It's impossible to assess either stenosis or regurgitation. There are a few recent developments. 4D flow, very promising technique. There are a few years that 4D flow was introduced in MR. It produces some really stunning images and also directly calculates regurgitation volumes, but it hasn't found its way yet into everyday clinical practice because it's very technically difficult to perform, and also not many centers have the sequences required. Automatic post-processing software, this is one I use, AI machine and derived and machine learning. You can perform also automatic LG measurement, and of course feature tracking in this left image. Some recent developments, the recent ESC guidelines for valvular heart disease has integrated, as I mentioned earlier, left ventricular and systolic volume for aortic valve assessment in asymptomatic patients, but it's only to be so it's not very well documented and studied. Future developments. We seriously lack CMR-specific cutoff values for severity grading, although I have to say that in the past years, quite a few studies have tried to answer this question, and I think we're very near it. Also, fibrosis imaging using T1 mapping. T1 mapping is a very important technique, and it shows us what happens at the cellular level, but there's a lack of standardization. Each center uses its own sequences, so we do not have big observational studies in that sense. So these are a few take-home messages. I think that CMR holds unique advantages. The most important is unrestricted imaging planes. We can really show detailed valve morphology and assess that. Although especially for the mitral valve and for small lesions, it's really challenging. We can accurately quantify ventricular volumes, mass, and function. Let's keep in mind that it remains a golden standard for that. Velocity measurement for stenosis, although I would argue that a good echo exam is superior to CMR. Regurgitation volume and fraction measurement, very accurate. Fibrosis imaging, very important in showing future adverse outcome. And of course, we can perform MRA in the aorta and pulmonary artery when we have dilatation. Thank you.
Dear Dr. Kolentinis, thank you very much for this excellent and highly educated, not only illustrative, but also highly educated presentation, delineating also the methodology of quantification in the different aspects of valvular heart disease. Really a very well done presentation as far as I'm concerned. We have two questions from the audience. One first question is addressing the rising frequency of multivalvular disease in the aging population. It is a question, for example, moderate or severe mitral regurgitation and moderate aortic regurgitation. How can CMR be helpful in the setting of multivalvular disease?
I would argue that CMR is perhaps the only modality that can answer that, because we have two different methods in order to calculate regurgitation. So, for example, when we have a patient with concomitant mitral and aortic disease, we can calculate aortic regurgitation through aortic flows, and then using the stroke volumes, we can also calculate the regurgitant volume in the mitral valve. So let me give you an example. Let's say that stroke volume from the left ventricle is 200 mLs. If the flow in the aorta shows 160 mLs, then we have 40 mLs of mitral regurgitation. And of this, and also we can directly calculate the aortic regurgitation.
Dr. Kolentinis, a second question. Can we refer a patient with surgically repaired Fallot tetralogy for CMR for pulmonary valve evaluation? Do we have any artifacts from sternal metal used for surgery?
Not only we do actually. It's very, very common to refer a patient for pulmonary regurgitation assessment. No, there are no major artifacts from sternal metal, actually. Very, very few artifacts. They don't interfere to our measurements, actually.
Thank you. Dr. Kolentinis, a third question from the audience. Is it reasonable to perform MRI when we have eccentric MR or AR, aortic regurgitation, jets on echo and TOE? So eccentric MR or AR.
Yes, actually, it is very. I would argue that maybe the most useful way to use CMR is these patients with eccentric jets. For example, when the aortic valve is involved, it's notoriously difficult to truly calculate the regurgitation volume, especially with eccentric jets. The same applies to a lesser extent for the mitral valve. CMR does not care where the jet goes; it just cares where the volume goes. So, and because it uses volume to calculate the severity, it doesn't matter if the jet is eccentric or otherwise.
Mm-hmm.
Dr. Kolentinis, yes, please, Samati.
Oh, no. Carry on with the questions. Carry on.
The interest on your presentation is really supermount.
Really nice.
Yeah. What about TR cutoff values? So tricuspid regurgitation. Perhaps important this question since the frequency of TTER procedures is rising and rising.
Yes. Well, for the time being, we use the same as mitral regurgitation. It's a fraction of over 40% and volume of over, let's say, 50 mLs. Yeah. But also you should have a dilated right ventricle. I think it's really important also.
Yeah. With respect, Michalis, can I?
Yes, please do so.
Yes, with respect to the last question, thank you very much, Dr. Kolentinis. Very, very nice talk, actually, very informative. With respect to the last question, the right ventricle plays a very important role with respect to the success of transcatheter post-transcatheter TR treatment. If we've got quite low right ventricular free wall longitudinal strain or radial function, the outcome with post-TR transcatheter treatment seems to be not very good. So the CMR can provide us with very nice right ventricular function estimates. But my question is for another thing, which is quite in fashion, I would say. The MAD, I mean the mitral annular disjunction, which is not a benign finding, and it is associated with elevated risk for cardiac arrhythmias, especially when this MAD, the mitral gain annular disjunction, is associated with LG either on papillary muscle or in periannular basal left ventricle. Would you like to comment on the usefulness of CMR with respect to MAD and prognostic significance of CMR?
Yes, of course. Thank you, Dr. Adamopoulos. My position on that is that actually it is the LG that drives the outcome. It is well known that when we have LG, we have adverse outcomes irrespective of the reason. I mean, obviously there is elevated strain in the free wall and especially in the ferrolateral wall. In these patients, we have mitral valve prolapse. I don't think it has to do so much as the extent of disjunction, as that there can be late gadolinium enhancement. If
Right.
the patient has no enhancement, I would be more assured that he has a benign prognosis, actually.
Right. Because some people, thank you very much, very nice approach actually, because some people press for earlier surgical intervention to reduce arrhythmic risk in mitral valve prolapse. Anyway, thank you very much.
Thank you.
Michael, would you like to carry on?